Thank you for tuning into our program this evening. My name is Enrique Robert Hilton, a co-host of this program, and my other two co-hosts are Dr. Edward Suman and Dr. Yvonne Kalampuda, who will be joining us shortly. We have a lot to discuss in an hour, and so we're going to get right into our discussion for this evening. This is our second series on fertility health. Our first series was in June on male infertility, which was presented by Dr. Denise Asafwe, a good friend actually of our guest this evening. So if you have not watched that series, we recommend that you do so. We highly actually recommend that you do so, as it will enrich your knowledge on this topic that we're going to be discussing this evening, specifically relating to the male partner. Again, this evening's discussion is on female reproductive health, infertility, and fertility preservation. And we are grateful to have one of the leading specialists in the reproductive field, Dr. Tia Jackson Bay. She's a talented surgeon and dedicated fertility expert who is focused on fertility preservation, IVF success, and great outcomes for her patients. We hope that you invited your friends and family members to tune in, especially those who are of childbearing age. I believe that's between 10 and 50 at the moment, but she will clarify that when she comes on the program. So let us get started with a brief introduction of our speaker this evening. Dr. Tia Jackson Bay is a reproductive endocrinologist and infertility specialist and board certified obstetrician, gynecologist who cares for patients at RMA of New York in their Brooklyn office. Dr. Jackson Bay completed her undergraduate education at Vanderbilt University in Tennessee. She then earned her medical degree from the University of Cincinnati College of Medicine while simultaneously completing her master's in public health from New York Medical College School of Health, Behavior, and Practice. She completed her residency in obstetrics and gynecology at Duke University Medical Center and joined RMA of New York shortly after finishing her fellowship in reproductive endocrinology and infertility at the University of Illinois at Chicago. Dr. Jackson Bay's professional interests include physician-patient education, IVF outcome improvement, global public health, and mentoring underrepresented college and medical students on careers in medicine. She's very passionate about reproductive justice and increasing access to fertility care for all. She was recently appointed a member of the newly formed ASRM, which is American Society of Reproductive Medicine, Diversity, Equity, and Inclusion Task Force, which will enhance opportunities in reproductive medicine for underrepresented minorities populations and reduce health disparities and access to care. She's a very busy woman, and so we are very grateful that she accepted our invitation to join us for this evening's program. So let us welcome our guest, Dr. Tia Jackson Bay.
Hello, thank you so much for having me.
Hello, thank you for accepting our invitation. Um, we are very, very grateful that you accepted our invitation to be on this program. And as I mentioned earlier, a good friend of yours did the first series on male infertility. And so we received a couple of requests to have one on female fertility health. And so we're grateful that you were able to join our program this evening. So we can get started. Just a quick housekeeping rules for our viewers. This is a discussion format. We're not going to have slides this evening. So please feel free to enter your questions, and Dr. Eddie will make sure that it is posted for our guests to respond to your questions. So Dr. Yvonne and I will get started with this evening's program. So before we dive right into the fertility part of our discussion, Dr. Tia Jackson Bay, I was just wondering if you don't mind explaining how a woman's health impact their fertility before conception.
Absolutely. And so, reproduction, pregnancy, trying to get pregnant are always going to be intertwined with your overall health. And so that's why we want to make sure that everyone is in the best possible state of health prior to pregnancy, during pregnancy, and for, the time after pregnancy, which is often very neglected as well, the postpartum period up to a year. And so there's multiple different aspects of your health that can directly impact fertility. But I think most importantly is that we want to make sure that every person entering a pregnancy is in the best state of health possible.
Okay. So, the term infertility in my opinion, get thrown out there very loosely. It means different things have different definitions for different people. So if you don't mind explaining what infertility actually means in respect to a woman's fertility health.
Absolutely. So, infertility is a medical diagnosis. It is not a bad word. Just the same way cancer is a medical diagnosis, even though there can be very negative associations with it. And so, I think it's important that we're not afraid of it, that we understand that it's a medical condition. It is not a curse. It is not something you did to yourself or something someone did to you. It's not a punishment. It literally means that some of the organs are not functioning the way that we anticipate them to, and therefore we need to figure out what the issue is and figure out ways to solve it. And so, the classic definition of infertility actually is, having regular intercourse. That means at least a week out of every, or I would say once a week out of every month, in a woman who gets periods regularly. So if you don't get periods every month, maybe every 2 months or 3 months or more, you may fall into a different category. But for a woman who menstruates regularly and is having intercourse regularly, we typically would anticipate that your chances for pregnancy are highest in the first year. And so, if you have not achieved a pregnancy in a year of trying, you meet the definition of infertility. I think that's important to know because oftentimes we meet people and they've been trying for multiple years without realizing that 3 years ago you actually met the definition of infertility. Another thing that's really important to remember is even though infertility is defined as 12 months or 1 year of trying without success, there are some reasons that you should be seen sooner. And so the most significant of those is age. Age 35 and older, we know that it can be harder to achieve pregnancy if the woman is 35 years or older. Therefore, you don't need to try for a year over 35. Actually, 6 months of trying is sufficient. And if a pregnancy has not resulted in that time, then we actually want you to come in and be seen in a doctor. Similarly, for women who are over 40 and are either trying for a first baby or a subsequent baby, we want to see you right away, because we know that there can be significant challenges to trying for pregnancy in your 40s. And so, in that case, if you've been trying 2 or 3 months and it hasn't been successful, we would rather see you then and, do an evaluation and possibly intervene if necessary.
Okay, I'll ask one follow-up question and then Dr. Yvonne can chime in if you have questions for Dr. Chiave. So I'm just wondering if you don't mind explaining on some of the causes of female infertility.
Absolutely. So when I think of female infertility, you think of all the different components that are necessary for someone to get pregnant. The one that we think about the most is probably the uterus or the womb where the pregnancy is actually carried. But there are multiple different components that are necessary and have to be functioning properly in order to achieve pregnancy. So absolutely, the uterus, we want it to, the space inside the uterus where pregnancy grows, we want that to be unobstructed. Sometimes women can have malformations in the way their uterus is shaped that just came from birth. Other times you may have surgeries that can cause scar tissue inside of the uterus. And then we may all be familiar with uterine fibroids, which are tumors of the smooth muscle of the uterus that are non-cancerous, but can cause significant impact when trying to get pregnant because of either where they're located, how large they are, how many of them there are. And so, there can be uterine factors in infertility. Extending from the uterus, you have the fallopian tubes on either side. And so most women will have two open fallopian tubes. In some cases, you may only be born with one fallopian tube, or your fallopian tubes may be damaged or scarred, either due to infection over the course of your lifetime, a prior ectopic pregnancy, or prior surgery on your fallopian tubes, and even certain conditions like endometriosis. And so making sure that there's no issue with the fallopian tubes itself is another important factor, because tubal factor infertility is actually one of the biggest forms of infertility, not just amongst African American women in the United States, but particularly in Africa. Tubal factor is huge.
Mm.
The next thing that you need in order to achieve a pregnancy are functioning ovaries. The ovaries are the storehouse for all of the eggs. Women are born with all of the eggs they're ever going to have. Unfortunately, we do not have the capacity to make new eggs over the course of our lifetime. So they're created when you were in your mother's womb, and these eggs are with you until the end, until they're essentially no more. And so, in order to achieve a pregnancy, an egg has to grow to a certain stage. It has to be mature, which is a process that happens through kind of hormonal signals from the brain to the ovaries. That egg has to be released from the ovary, captured by the fallopian tubes, where if you have intercourse at the right time, the tube is kind of like the reservoir from where sperm and egg will meet. And so, again, you have to have functioning ovaries. You have to have ovaries at all, which meant that they weren't removed from surgery or absent from the time that you were born. And then the hormonal signals between the brain and the ovary and other, endocrine organs in your body have to be just so. So those are some of the different things that I think of in terms of female factor infertility. Yes, age plays a huge role. I know we're going to talk a little bit more about that later. But then male infertility is a big part of overall fertility. And it's something that can't be neglected because, in some cases, up to 50% of couples may have some component of male factor, either as the sole factor or in combination with female factors of infertility. So it cannot be ignored.
Okay, Yvonne, you have a question? Or
Yeah, can you hear me?
yes, we can hear you.
That's really insightful. Just to know the different things that need to be in place for you to actually conceive and have a baby. I think most people don't think, about all the other factors. I know, in our community, infertility is something that most people don't talk about. And are not comfortable, sharing their experiences, and that typically that kind of makes it a non-existent field. So I wanted to ask, what are some tips that you have for people dealing with infertility that help them like build on their relationships, not just with their partners, but also with others in their community, and help them be comfortable, sharing their experiences, and also that way they might be able to get additional help that they may need.
I think it's so important for persons who are dealing with infertility to be honest about it, because I think that is actually our biggest area of advocacy. Is it's something that can be very traumatic to have to encounter. It could be life altering in terms of how it makes you feel about yourself, how it affects your relationship. There might be all kinds of pressure from parents and in-laws and society, even your own peers about when and where you can have a baby. But by being more honest about it with your close circle, friends, sisters, church members, then people will come forth with their stories, and they'll know that they're not alone. Or they may have dealt with this years ago, but you just see the baby and you don't know the things that they had to go through. And so they may share tips or a doctor's name or things that they tried. And so I think that's probably first and foremost. Too, for Christian women, I think it's important to remember that, the barren woman is something that is referenced throughout the Bible. And so, if that alone doesn't show you how big of an issue this is, how long of a period of time that, infertility has been a subject, but also a source of hope in a sense that, miracles happen, and there are possible ways to achieve a pregnancy. There's all sorts of examples in the Bible, from adoption to gestational carriers, what we call surrogacy, and to all different kinds of things. So I think that's really important to remember, and to draw upon, but also to create your community, reach out to other people and try to figure out maybe things that have worked for them, physicians that they went to see. And I think most of all is not to keep it to yourself, because in the meantime, while you're silent on this issue, you could be being in treatment, could have evaluation that could help you, instead of kind of prolonging the experience due to shame.
Okay. I think just to add to that too, probably is also a comfort level of that individual and sharing with whomever, that's their community members may be. I think sometimes we're taken back when people just approach you who do not have that bond or relationship with you, asking you personal questions. Fertility health is a very personal matter. So I think before you approach folks about it, I think you should try to make sure that you actually have that type of rapport with that person. So you mentioned something earlier, and go ahead. Sorry, Dr.
And I
Lucia.
was going to say, I mean, that's something that's very important, in our culture is, people being in your business. And that is something that is not going to go away easy.
Mm-hmm.
And the aunties are going to talk and do what they do. But, to some degree, communicating with your partner, if you're in a relationship, communicating maybe with, the people who you're closest to in your family about how this is affecting you, about, things that you're going through, then you can start to build your own little support team and support network. It might also involve thinking of some responses to the questions and to the aunties. And sometimes that response is just being honest. And it'll shock the pants off of people because it makes them feel like, oh, that's not the response I was expecting. I didn't know. I'm
Right.
sorry.
Yeah.
And, sometimes that's worthwhile. Again, yes, it is definitely a comfort thing. But, we have to start to break down these walls and break down this barrier so that we can have more open conversations about what's really going on.
Yeah. Thank you. Thanks for adding that. So you mentioned earlier about fibroids, and I'm just curious because there's so many different treatments for fibroids. And so for someone who's trying to conceive, what would be the appropriate treatment if they did have fibroids?
So it depends. Not all fibroids are created equal. Just because you have fibroids does not mean that it would be an issue in your pregnancy. The things that matter most about fibroids are size and location. And so, location being, there's three different kind of layers to the uterus. One is the endometrium, it's usually the lining of the space where pregnancy grows. Another is the actual muscle layer that kind of can grow and expand with a pregnancy. And then there's an outer layer. If you think of like the skin of an orange or a peel, it's the outermost layer, which we call the serosa. And so sometimes fibroids can be just under that skin layer, which maybe don't have as much of an impact on fertility. Sometimes those can be the most bothersome because you can feel them through your belly. Maybe it pushes into your bladder or pushes into your rectum, but they may not have as much of an impact on fertility. On the other extreme, fibroids that are in the endometrial layer, what we call submucosal fibroids, those tend to be in a cavity, taking up space where early pregnancy needs to grow. Sometimes those also contribute to very heavy bleeding. And can be therefore some of the most symptomatic fibroids because you notice it because your bleeding is so heavy or you have random bleeding throughout the month. And those may need to be surgically removed prior to pregnancy. Intramural fibroids are the ones that are in that muscle layer of the uterus. And so, again, it could be a little bit of a gray zone in terms of whether or not they need to be treated at all. Sometimes they may need to be surgically removed. If you opt for, something like a medical treatment where you take a medication to decrease your hormone levels and possibly stop the fibroids from growing, that's something that, unfortunately you can't do at the same time that you're trying for pregnancy. And so that's why we really want to make sure that women are aware of these things well in advance of wanting to try, because then they can maybe act upon those 6 months or a year or more before they're ready to start trying for pregnancy. So there's no one size fits all when it comes to fibroids. It's also not uncommon that your doctor says we shouldn't do anything about them. You have them, but it's okay to try to get pregnant. And so I know on both ends of the spectrum, women may feel kind of shocked if someone tells them to have surgery or shocked if the doctor says there's nothing to do. But it may all depend on the size and the location of the fibroids they have and the number.
Okay. Would they, have you noticed whether not having the surgery, whether it contributes to miscarriages if someone has fibroids?
So there can be, if there are large fibroids or a large burden of fibroids, which means maybe they're smaller, but there are many of them, it can certainly impact your pregnancy outcomes, increase your risk for miscarriage, increase your risk for needing to have the baby early or needing to have a C-section or something like that. But again, it's not as simple as like have surgery or not have surgery. It all depends on the individual case. And so I would say if you're someone who's been diagnosed with fibroids, if you're concerned about how it could impact your fertility, you can start with the doctor who made the diagnosis. If you're not satisfied with that conversation, find a fibroid specialist in your area. They can talk to you more specifically about what should be done, either now or in the long term. What's your timeline like to pregnancy, and therefore what you should do or look out for. Sometimes the only thing to do is maybe to repeat an ultrasound in a year or have an MRI so we can kind of further characterize the fibroids and see if they need to be acted upon now or not.
Okay. Dr. Yvonne, do you have a question or?
Just a follow up to that. So, will the treatment options be similar for, let's say, a woman who has fibroids but has been told that it's pretty much benign? There's nothing for you to do, is just leave it alone. However, you get pregnant, and during your pregnancy, you notice that, or the doctor notices that your fibroids are growing with your pregnancy as well, or there's been some changes. Are the treatment options there different from what you would get pre-pregnancy?
Yes, so you cannot treat fibroids in pregnancy. And it is not uncommon that fibroids can grow with your pregnancy. The only thing that we can do is monitor them with the growth of the pregnancy and see what happens after the baby is born. So we can't do any surgery on the uterus while the uterus is holding the pregnancy because it can jeopardize the pregnancy. But that's not an uncommon thing that fibroids grow as your uterus grows. Sometimes women find that after the uterus shrinks back down after pregnancy, that the fibroids also decrease in size. Sometimes, sorry about that, they can be more symptomatic after delivery or less symptomatic, actually. And so it's just a matter of each individual practice, but it's important to know that you can't do anything about the fibroids once you're actually pregnant. So if that is something that you're concerned about, it needs to be done in advance.
Okay. So earlier you mentioned a little bit about the male factor. And so I was wondering if you don't mind letting us know how much infertility is attributed to the male partner.
Yeah, so classically, anywhere from 30 to 40% of all couples who come with infertility may be impacted by male factor. And as I mentioned, there may be couples that have both male and female factor. And so that's something that's important to know. And I think it's more important for the women to hear because a lot of times men give them a lot of resistance about coming into the evaluation, performing the very basic semen analysis, which is kind of like our first line for assessing male factor infertility. But it's important to know that there could be more than one factor in the infertility, and you don't want to miss something like male factor. Another important thing that I think Dr. Denise probably mentioned is that semen analysis can really be seen as a window into male health. It's not uncommon that men who have infertility may be found to have other conditions, sometimes high blood pressure, diabetes, or even testicular cancer. Abnormal hormone levels can all be kind of at least suggested based on the semen analysis. So it's an important part of men's health as well, and that we don't want to overlook just because the men think that nothing's wrong with them.
Yeah. And especially when they've had kids before, when they were younger, they might assume that they still have that capability and there's not a problem later on down the line, but they definitely probably need to be checked. Dr. Yvonne, do you have another question? You can feel free to chime in whenever.
No, I'm good. I mean, it's and also like most males don't realize that some of the risks that women have when it comes to infertility is pretty much the same. The age can also play a factor, health, in general, as you said. So those were great. Yeah.
So, and before we jump into other discussions, I want to ask you I've heard the term unexplained infertility. If there are all these tests and all these procedures, why is there unexplained infertility as a diagnosis for some folks?
Yeah, so unexplained infertility is kind of a catch all term. That means that you meet the definition of infertility, not being able to conceive after 12 months of trying, but all of the tests that we do come back normal. So your egg count looks normal for your age, or the semen test looks normal. The fallopian tubes are open. The on ultrasound, the uterus looks fine. And so sometimes there may be circumstances where we don't exactly know why there's infertility, even though we know that you meet the definition for infertility. And, it may be that there are other factors that we just don't have good tests for. But one thing that's important to know is unexplained infertility is not uncommon. It could be up to 25 to 30% of all couples that we see. It doesn't mean that there aren't treatments for it. We would still proceed with treatments in a certain way, knowing that diagnosis. So it's not something that's uncommon. Unfortunately, it means that it just evades the limitations of our testing at this time.
So then that makes me wonder, because as an OB, I'm wondering why that when a woman goes in for their regular GYN checkup, that they don't. I feel like the OBs or the primary care physicians don't necessarily talk about fertility health and say, hey, you're at this age. These are the tests that we should try to, do in case you're considering having kids. I feel like the OBs are more concerned about making sure that you have the pap smear, if there's any sexual transmitted diseases, screening that needs to be done, your mammogram, and kind of stops there. But fertility health is not really a component of a GYN visit. How come? Why is that?
It's a little loud where I am, so let me know if you have any trouble hearing me. These are New York
Okay.
City sounds. But, I will say I'm an OBGYN first. And so I understand the constraints to do everything that you need to do for women in their visits. We had to make sure your cancer screenings are up to date, breast cancer and cervical cancer. We want to make sure that your mental health is okay. We want you to not get pregnant if you don't want to be pregnant. So we ask about contraception, even into your cholesterol levels and cancers in a colon cancer screening and all of these things. So sometimes fertility conversations get lost in there. I would think that in general, this is something that I talk to a lot with OBGYNs. Next weekend, I'm going to be talking to a room full of OBGYNs at the National Medical Association conference in Atlanta. And these are the kind of things that we talk about. How do you engage your patients? How can you fit this into your 15-minute visit? And maybe it's not that they need to deal with it right then, but you just put it out there. Are you looking to have children in a year? Are you looking to have children in 2 years or 5 years? Just so that they know that that door is open, and it can pique your mind to remember what are the things that you need to be talking to them about. Do they need to be on a vitamin? Do they need to be working on their weight or their blood pressure? Are we screening for fibroids, things like that?
Yeah.
So I think overall there's some gaps, in terms of unfortunately asking about that and engaging. But I think for anyone who wants to learn more about their fertility, it's important to know you can be seen directly by a fertility specialist. You don't have to kind of go through your OBGYN. A lot of times your insurance company will allow you to be seen by a specialist without a referral. And so in that case, you can go to your insurance company, see who the providers are in your network, or work, with providers that you're aware of, and schedule an appointment to be seen. And to be honest, in that way, I think you may get more from it. You may have more conversations about your goals, about prior contraception, prior pregnancies, what went wrong and what went right. A lot of times in our initial conversation, we'll also do an ultrasound at the same time as the evaluation. We may get some blood work. We may ask questions that OBGYNs don't normally ask. So in that regard, I think it might be more worthwhile to go directly to a specialist.
Okay. Well, it's good that you mentioned about the insurance, because a lot of jobs do cover, for, infertility, and some don't, but a lot do than most people can imagine. You hear people say, "Oh, I didn't even know my job covers this." Because you definitely have to look at those benefits when you sign up yearly to see what is covered in terms of your health care. Dr. Yvonne's mute is off, so
It definitely helps. As the patient, being proactive and going out and seeking that help and resources for yourself definitely helps as well. Because yeah, the doctors have a lot of patients they're dealing with. So once you bring their attention to something, they can guide you in the right direction as well.
And I think, doctors are human beings too.
Correct.
And we have biases. We have kind of maybe some mental checklists. It's like, sometimes you go to the grocery store and you get what you can and then you forgot, like, oh, I really went to get chicken and I didn't even write that down. Or you go with a checklist and then you're like, oh, I didn't plan to buy this other thing and you didn't get it. So there are certain biases that physicians could have in which patient needs what. Maybe they look at your chart and see that you're single and they make an assumption that you're not interested in fertility. And so that's why I think being your own advocate can be really important, to bring it up, to bring it to their consciousness, and to know that anyone can have those kind of limitations. I think we can't ignore the impact of discrimination in medicine and racism as a factor as well. And thinking that Black women don't have issues with fertility is something that a lot of physicians still think is true. They think of the need to control our fertility instead of enhance or improve our fertility. And so in that regard, women may have to be advocates for themselves until we can kind of get this healthcare system together to realize all women are at risk of infertility. There's no one group that's more or less fertile than another. It can impact everyone. It can be just as equally devastating for everyone, and certain cultures may have more hesitancy bringing it up. And so, the onus is again back on the physicians to, just introduce it as a topic. I see, you're coming up for your birth control. You still want to continue on it. And, sometimes it leads into other conversations. Oh, you're having really heavy bleeding. Huh? Why would that be? Or, oh, this is not addressing your pain. Your menstrual pain is getting worse, and why would that be? And so, sometimes it can even give you clues as to other conditions that are happening that can have a reproductive impact, but don't, even if you're not there for a fertility checkup.
okay. So you mentioned a little bit about some of the tests and procedures that are done during the consultation. I was wondering if you can expand on it and also talk about treatment options available for women dealing with infertility.
Yeah, so as I mentioned, just going along, what are some of the most common factors in infertility? We want to make sure that there's nothing obstructing the uterus. One, that there's a uterus there, because some women may be born without a uterus. And so a pelvic ultrasound is really one of our first line tools. It's something that reproductive specialists, find very handy. We do tons of ultrasounds, make lots of diagnoses that way. Anything from fibroids, which are those smooth muscle tumors of the uterus, to cysts that can be present on the ovaries, and that can have multiple different kind of causes why those cysts are there. We also use other imaging modalities such as a hysterosalpingogram or HSG. And this test is typically done with radiology because you have to take an x-ray of the pelvis at the same time as you're injecting contrast into the uterus. And so it'll fill the uterus, flow through the fallopian tubes, and the contrast flows out into the open space in your body called the peritoneum. And so through that test, we're able to assess, are there problems with the uterine shape? Are there problems with the fallopian tubes? Are the fallopian tubes open or are they blocked? Is one blocked or both blocked? Where does the blockage occur? Are the fallopian tubes damaged so much that they're dilated? They're very swollen and look different on imaging than we would expect. And so that can be a very important test. In terms of the ultrasounds, I mentioned we're able to look at the ovaries, and sometimes it helps us to know, how efficiently the ovaries are functioning based on how many antral follicles, or very small little spaces where some of the eggs are growing, how many of those are present each month. And so you may hear us counting antral follicles. We can also get a sense of how efficiently the ovaries are functioning based on some blood testing. Examples of those may be anti-Müllerian hormone, or AMH, or you may be asked to come back on a certain day of your period, on the second or third day of your, while you're actually still bleeding, to get blood work. And the reason being is because those hormones should be in a certain range at that very critical time, and it gives an idea of how well the ovaries are functioning. Other tests, as I mentioned, there may be other hormones that it can impact your reproduction. Things like your thyroid hormone, or a hormone called prolactin, which is made in the brain. And so you may get that testing done. We also look at other factors. Are you anemic? So we'll get a blood count. Are you deficient in vitamin D? So we may get that. Are you currently experiencing any sexually transmitted infections? And so we may do that screening, or things like pap smears. And so even though it may not directly relate to, causes of fertility, those are some of the things that we want to make sure are doing okay before you start trying to get pregnant. And then, as I mentioned, another important test would be the semen analysis, which is where we actually have male partners ejaculate into a cup. It's a sterile container. And that way, our andrologists, or people who kind of analyze sperm, can take a small portion of that semen and run multiple tests. We look at the sperm count, actually counting some of the small sperm in there, very small cells. We look at how well the sperm move. And are they just moving in place, or are they moving kind of with a forward progression? There's some very strict criteria about how sperm should be shaped. And we look at, what we call morphology, or the shape of the sperm. And also the amount of ejaculate is important. As I remember, I mentioned these can be windows into all different health problems for men. Anything from a genetic disorder, to, obstruction in the testes, to chronic illness like hypertension or diabetes. And so it's an important part of the evaluation.
Okay. So even though women, we can grow more eggs than what we're born with, if you do a semen analysis and the man's sperm count is low, I received there are supplements that they could take to bring that up. Correct.
Well, it depends on why it's low, because it
Okay.
can be low for all different reasons. Sometimes it's just a fluke, because
Mm,
maybe the not enough got into the cup, or they've been dehydrated, or had an infection, or had some other illness that causes just a temporary decrease. So if there's an abnormality, typically we repeat it, and we'll say to repeat it in 2 to 4 weeks, sometimes even longer. Maybe if they're heavy smokers or heavy alcohol drinkers, we may want them to abstain from that offending substance for a while, and then repeat it and see if that helps. But there could be a myriad of issues why you have a low sperm count, while you have sperm that don't swim well. And so, getting the semen analysis just opens up the gate for us to investigate why that could be, before just going out and starting on supplements, because it could be a red herring for something else.
okay. So in terms of treatment, um, for a woman with infertility, I guess, how do you make the decision as to whether they should proceed with IVF versus intrauterine insemination, IUI?
So the treatment will be directly correlated to what the issue is, what's
Okay.
causing the infertility. If it's a problem with sperm, then sometimes to help the sperm get closer to the egg, we would use something like an intrauterine insemination, as long as there's sperm there, enough sperm there, and there's sperm that move. If there's an issue with, some women may not produce an egg every month, or they may not ovulate an egg every month due to conditions like polycystic ovarian syndrome or hypothalamic amenorrhea. And so in those cases, they may need some help just to ovulate the egg, which may require oral medication. And then sometimes we combine that with the intrauterine insemination. That means placing the sperm inside the uterus, not just inside the vagina as it would be with intercourse. Um, in more advanced cases of, male factor infertility, if the sperm are very don't move very well, or if we had to extract sperm from the testes or the sperm count is very low, that may be an indication for in vitro fertilization. And so that may be a reason to kind of skip the IUI step and go straight to in vitro fertilization. Similarly, for women, if the fallopian tubes are blocked, either one or both, that can impact your chance of success. Particularly if both tubes are blocked, then the sperm and egg don't have a way to meet. And so, in order for sperm and egg to meet, you have to go through in vitro fertilization. In vitro fertilization has a few different steps. One, you use injectable hormones to help as many eggs grow in a single cycle as possible. So instead of your body's default of only having one egg grow that month or in that 2 week period, hopefully with in vitro fertilization, you'll have multiple. That's advantageous because we then will remove those eggs from your body in the same day procedure. And so by removing those eggs and getting sperm from your partner, we can actually inject the sperm into every egg. And that way we can, increase the chances for fertilization. Fertilization is the process of sperm and egg joining and hopefully create an embryo, which is the same as what happened in your fallopian tube. But if there's issues with the fallopian tube, that can be accomplished outside of the body. Then in order to achieve a pregnancy, as the embryo grows, it gets to the right stage, we can place that embryo inside of the uterus to achieve a pregnancy. Some cases, women may have to go straight to IVF as well. One is older age. And so, even with something like unexplained infertility, for women aged 38 or older, that might be the first step because it decreases the time to pregnancy. We know that it could be harder for them to get pregnant, even with an IUI. And so, that might be a reason that that's suggested. If someone has severe endometriosis or a low ovarian reserve, that might also be another reason to go straight to IVF, just because we want to improve the chances for success. It's not just about the journey, sometimes it's about the endpoint. And if the endpoint is to have the baby, then we want to get you there as soon and safely as we can. Other times, patients have been through cycles of IUIs, the intrauterine inseminations, and for whatever reason, it did not work. And so, in those cases, if you've tried either 6 or sometimes even fewer, like 3, and you want to move on to a treatment with a higher success rate, then that would be another reason to go on with IVF.
Okay. Do you mind expanding a little bit on endometriosis? I don't think a lot of people know how much that can influence fertility.
Yeah.
That and perhaps PCOS a little bit.
So, endometriosis is a condition where the endometrium, those cells that grow inside the uterus every month and then come out when you get your period, those cells are present in other places aside than just where they should be, which is lining the inside of the uterus. Unfortunately, they respond to hormonal signals in your body because they don't know that they're in the wrong place. So, when it's time for them to grow, they grow. And when it's time for them to die, they die, but they don't have an exit point for your body as if they would if they were in the uterus. So, unfortunately, some of that cell death can cause scarring, it can cause inflammation. And unfortunately, over time, that can lead to adhesions and scar tissue, which can be very painful. So, one of the most common signs of something like endometriosis is very bad pain with periods. And this is something that is very much overlooked in women of color because old studies concluded that white race was a risk factor for endometriosis. And we now know that not to be true. But that is something that is stuck in doctors' heads. And so they don't remember that, oh, she comes in with very bad periods. This is a girl. She can't go to school. She needs to stay home from work. She has to change social plans because her periods are so bad. That is not normal. And if that's happening to you, then you definitely need to make sure that someone is doing an investigation to figure out why. Endometriosis can impact your fertility because it leads to that scar tissue. It leads to pain. Sometimes it can lead to, either obstruction or distortion of the fallopian tubes, which make it harder for sperm and egg to meet. It can contribute to cysts in the ovaries that can be very painful, particularly if they're very large or they rupture. And so all of these different factors, and they also, those cysts can kind of cause inflammation in the ovary, which makes the egg count go lower over time, like earlier than we would expect it to. And so those are all of the reasons how endometriosis can negatively impact infertility. Now, just because you have endometriosis doesn't mean you'll have a hard time getting pregnant. But if you are diagnosed with it, it is something to kind of think about and consider in terms of what is your reproductive plan. Could you need help in the future? Maybe knowing about that in advance could be helpful for you later down the road. Sometimes women with endometriosis can benefit from being placed on birth control, because by taking those exogenous hormones, it turns down the amount of hormone that your ovaries are making. And so sometimes that can help those endometrial cells to be very calm and not cause so much inflammation. It can be very helpful. Something like PCOS is a different entity in that women with PCOS, it's an endocrine disorder, which, the ovaries get so much attention, but it really is a multi-systemic disorder of typically elevated male hormones, which we call androgens. So this is testosterone and another hormone, DHEAS, which can be very elevated. If those hormones are high, it can be hard to help the ovaries to ovulate. And so while there may be many eggs present in the ovaries, the eggs are not kind of leaving the ovary in the way that they should every month, and it can make it very difficult to achieve pregnancy. Women with PCOS may also be at increased risk of heart disease. And so we talk about the relationship between PCOS and obesity. They may have a harder time losing weight, or may find that they gain weight more readily, or have a different kind of fat distribution of their weight. Women with PCOS may also be at increased risk of endometrial cancer, particularly if they don't get a period every month. And so if that, a young woman who their period skip 6 months a year, that is not normal. Even though no one really wants to have a period, that's not okay, and they should be evaluated to make sure that they're not at increased risk of cancer of the uterus or endometrial cancer. Women with PCOS are also at increased risk of getting diabetes in their lifetime. And so many of them, even young people, may come in and they're already pre-diabetic. And so it's super important for them to, one, be, recognized, to be diagnosed, and to have some of these other factors checked, so that if they're pre-diabetic, that we can prevent them from going to full-fledged diabetes. If they're already diabetic, then we need to get that under control for their overall health, but certainly before they become pregnant.
Okay. I think we've talked a lot about infertility. I have a ton of questions more about that, but I'm sure there are people who tune in to listen to fertility preservation. And so we only have like 10 minutes for this. And so if you don't mind expanding on what fertility preservation is and how is the process accomplished?
Absolutely. So, fertility preservation is a way to preserve your current state of fertility for future use. So, it typically involves what we call cryopreservation, or freezing. You can freeze eggs, you can freeze sperm, or you can use eggs and sperm together to make embryos and freeze those embryos. And that's all to use later in the future. Other areas of fertility preservation that we don't talk about are certain surgical procedures, or certain techniques that may be done because we know that this person may want to have a child in the future. And so sometimes, especially in the cancer world, if you have a cancer that involves your uterus, your fallopian tubes, your ovaries, your cervix, it may be worthwhile to ask the doctor, is there a fertility preserving option? Could I be on one treatment versus another instead of removing everything now? Sometimes the answer is no, but I think it's worthwhile to at least ask, because sometimes you may have opportunities to do something like freeze eggs before some of those important organs are removed. So the process of fertility preservation now is becoming more and more popular, because women may be freezing their eggs because they're not ready to have children, but they know that they want to have children in the future. And so it's a reasonable option for anyone who that is very important to them that they have children. that they know that they're not in a position now to have children, maybe within the next 1 to 2 years, but they also want to have the option to have biologic children. And so by doing something like egg freezing, which is actually a very identical process to IVF, the only difference is what happens to the eggs when they come out. So typically, this involves about 2 weeks of taking injectable medication, and that will help multiple eggs to grow over those 2 weeks. And then the eggs are removed via a same day procedure. When you freeze eggs, the eggs are frozen the same day they're removed. When you're creating embryos to freeze or to later implant for IVF, the eggs are injected with sperm, grown into embryos, and then typically the embryos are either frozen or transplanted back into the uterus. So the process is very much the same. Some benefits of fertility preservation are, as I mentioned, being able to access your current fertility for future use. So if you freeze your eggs at 32 and you want to use them at 38, your chances of success should be closer to a 32-year-old version of yourself than a 38-year-old version. So that can be very helpful. Um, some of the other I would say drawbacks for fertility preservation are cost. It's not frequently covered by health insurance, and so it may incur an out-of-pocket cost of up to $10,000, which could include medication in some places and some places not. The medication itself can be another $3,000 to $5,000. There are more and more companies that are covering fertility preservation for their employees. And so that's a big bonus. You should look into your human resources and your fertility package to see if that's an option for you. Because if you're at a job now that covers it and you're interested, it might be worthwhile to pursue it now before you transition to a job that maybe does not cover it. For some people, they may have to pay out of pocket. There are also financing options that are available. And so I would always say, if you're interested in it, seek a consultation with a professional to learn more about it, to see what the options are for yourself, depending on your age, your relationship status, your own health. And then you can make the best, decision for you.
So I know you're based in New York,
Mhm.
but do you do telehealth if someone was to try to get a consultation with you?
Absolutely. So I see patients probably from all over the country and sometimes other countries. I think the most important thing is that you are seen by a provider that you're comfortable with. And that, in some cases you may have to be willing to travel for care. In other cases, you may be able to get some of the care locally and then, travel for maybe the bigger things like IVF or something like that. And so there are definitely options. I know a lot of people are going to live in places where they may not have immediate access to a fertility specialist. I would say usually if you're using health insurance, start with your health insurance to see what is covered and who is covered and who you can go to. And then otherwise you can, look around and go from there.
I had additional questions about what if the woman's egg is an issue in terms of the couple not conceiving. But I
Mhm.
think I will wait. Hopefully, you'll come back to do another segment so we can talk about the donor process and all of that if, um, if time permits next time. So, Dr. Yvonne, do you have any further questions before we wrap up?
No, I'll save them for next time.
Okay. So, Dr. Jackson Bay, thank you so much. This was an excellent presentation, and I'm sure that our members in the community gain a lot from this discussion and hopefully have a better understanding of how they can improve their chances of conceiving and having children and hopefully preserving their fertility in the future. I felt like the conversation was very, very short, but there is a church program, so I do have to get up. I'm hopeful that you will come back.
Yeah. Well, I hope that that helped answer a lot of questions for people. I think, as we mentioned earlier, there's a lot of kind of stigma around infertility, a lot of shame, can be blame. I think the duty is on all of us to stop that. Even if you hear some hot gossip about so and so who can't have a baby, stop the conversation and set the record straight, because that could be you who's being talked about in those circles sometimes. It could be your sister, it could be your daughter. And so it's important to, kind of really stand up for each other in these spaces and kind of, open the doors and make sure that we can have these discussions without shame or fear.
That That sums it up. Exactly what I was thinking. So thank you for adding that. So Dr. Eddie, I don't know if you're there, but you didn't put any questions up. Hopefully we answered any questions that our viewers may have had. But thank you again, Dr. Jackson Bay, for coming. And I will be reaching out again to make sure that we schedule another segment of this discussion. So have a wonderful evening. I know you also have a program at 8 o'clock. So thank you again.
No, thanks so much for having me. I hope you both have a great night.
Thank you. You too. Bye-bye. Dr. Eddie's not coming on. I'm going to wrap up so he can click us both off of the screen. So thank you, family, for watching this program. And as I mentioned, I hope this was very informative to you. If you have not watched the first segment first, we ask that you do so because it will definitely add to your knowledge about fertility health. And in closing, I just would like to add that fertility health, as Dr. Jackson Bay said, is a personal journey. So let us be respectful of individuals' privacy. And as sisters and aunties in the community, our role is to support by praying and giving a young woman their space and privacy as they navigate this long, long journey. So we thank you for tuning in. And as I mentioned, there's a church program coming up at 8 o'clock. So make sure you tune in for that. We will be back next month. Dr. Yvonne will be back next month with her second segment on nutrition. So please make sure you do tune in for that. Have a wonderful, wonderful evening. And hopefully Dr. Eddie will be back on screen as well next time. he had 2 meetings going on, so that's why you haven't seen him. So have a good evening, and we will see you next time. Take care. Bye-bye.
Bye.
Bye. Bye, Dr. Yvonne.